I'd like to introduce the next speaker, Dr. Inmaculada Cerecedo. She is a consultant allergist currently working in Hospital Clínico San Carlos, one of the main teaching hospitals and research centers in Madrid, Spain. She trained in allergy in Madrid. She completed her training at Jaffe Food Allergy Institute. Most of her research focused on food allergy. She is currently the lead investigator of an early intervention multi-center study to evaluate the safety and the efficacy of milk ladder in babies recently diagnosed with allergy, milk allergy. The talk will be oral immunotherapy for severe food allergy. Where are we?
Hello, good morning. Can you hear me well?
Yes, we can.
Hi, good morning from Madrid. I'm Inmaculada Cerecedo, and I would like to start by saying thank you. It's been an honor to participate in this first Emirates Allergy and Clinical Immunology Conference. So the topic of my talk today is oral immunotherapy, and here you can see my disclosures. I would like to talk a little bit about the epidemiology of severe food allergy and to continue with some data of efficacy and safety. It is very important, the initial evaluation and to manage the expectations of the patient and the parents. And if we can increase the safety of this procedure by using omalizumab. At the end, I will give I will mention briefly some of the new approaches for treating food allergy. So is severe food allergy increasing? Some of the studies to illustrate the prevalence of food allergy across the world. In the United States, University of Chicago did a cross-sectional study, and over 40,000% adults completed the survey. And they estimated that convincing allergy was 10.8%. And half of these patients had experienced at least one severe reaction, and 1/4 of them had been prescribed adrenaline. Same group studied the prevalence in children, and they found that 1 in 12 children are likely to suffer from IgE-mediated food allergy. And this is consistent with previous study. In Europe, as part of Europe-Preval Consortium, 8 centers evaluate the prevalence of food allergy. And the interesting thing here, and it has been mentioned before, there are large regional differences, not only in foods that are involved or foods that cause reactions, but also the prevalence of the disease. When we look at probable food allergy, measuring a specific IgE to the foods, we see that it's 1.9% in Reykjavik, and it's 5.6% in Poland. In Australia, HealthNet study found that over 10% of the population of 12 months old infants had a specific IgE-mediated food allergy, and this was confirmed by oral food challenges. When we look at anaphylaxis, we see an increase in hospital admissions over the last 10 years. And this is constant in all the series, all around the world. This is particularly higher in children. We see higher increases in children, but we don't see an increase, a parallel increase in fatalities due to anaphylaxis. Taking a closer look to these studies, we see this register in the UK that the higher increase is in children younger than 15 years, old. And if we split in a bit more, we see this study in Spain that the higher increases in school age years, so 4 to 9 years old. And the highest increases are in egg, milk, and peanuts. When we look at the more severe cases of anaphylaxis, we see, as we expected, that peanut and tree nuts are responsible for over half of the admissions to ICU units. And it's the same when we analyze the cases of fatal anaphylaxis. But interestingly, in children, in younger children, milk, which is not so prevalent as compared to peanut, is responsible for 24% of the deaths in young children. So here we can see how important is food avoidance and how difficult is that, how dangerous accidental exposures are, as it was mentioned before. So do we have an effective treatment for IgE-mediated food allergies? What is oral immunotherapy? This picture here reflects this blue line that is the reactivity threshold. So it's usually very low and it changes. It's as low as 125 milligrams, and this is about a third of a peanut only. So if the patient is exposed to a lower amount, there will be no reaction. But if the patient is exposed to a higher amount, there will be a reaction, and eventually with a higher exposure, there will be an anaphylaxis and there will be a need of adrenaline. What we get with oral immunotherapy, by exposing the patient to sub-threshold amounts of the food, we are able to increase the reactivity threshold, and we reach what we call a desensitization state. There's a lot of information of the immune mechanisms involved. I don't want to talk very much about it, just to mention the importance of mast cells, eosinophils, and basophils during the early induction phase, and B cells in the production of IgG4 during late induction phase. In different centers, in different studies, there are different treatment schedules. All of them start by a baseline screening of the patient that we will talk a bit more later in the presentation. And there are usually 3 phases in the treatment. There's an initial dose escalation performed at the clinic where we reach in 1 or 2 days 10 to 25 milligrams of protein, continued by a dose escalation phase when we give incremental amounts every week or every 2 weeks. So the patient comes to the clinic every week or every 2 weeks, and then they continue having that amount at home until we reach what we call the target dose. The target dose can be low, as 300 milligrams, the equivalent to 1 peanut, for example, or 4,000 milligrams, which is a serving dose of the food. It's a glass of milk, or a full egg, or 15 to 20 peanuts. And these are 2 different approaches. We have low dose oral immunotherapy that aims to protect against accidental exposures, and we have high dose oral immunotherapy that aims to reintroduce the food in the kids' diet. There has been a lot of debate whether oral immunotherapy should be performed in the clinic as daily practice. And so far, the European Academy of Allergy and Clinical Immunology has been the first scientific society to endorse this treatment. And the guideline published in 2019 that will be updated this year are based on this meta-analysis and systematic review and meta-analysis that include the 23 trials published back then. So the meta-analysis shows a substantial benefit for patients undergoing oral immunotherapy with only 3 foods: milk, egg, and peanut. As you know, there are other foods that have been studied, but the information is limited or to only one study or one series of cases. So for milk in young kids, there's a strong evidence that oral immunotherapy is able to increase the reactivity threshold, is able to desensitize the patient, but we only have weak evidence of the efficacy of this treatment after the continuation, how effective is after finishing the therapy. There are less evidence for egg because we have less trials available for this food. And there's again a strong recommendation for peanut. What happens with adults? Well, there's some publications, but very, very weak evidence. And there's only one trial for peanut. So there's no really evidence to recommend the use of this treatment in adults. So what we see as well is that there's no difference between, in terms of efficacy between milk, egg, and peanut. And we don't have enough information to recommend a particular dose or a particular interval between doses. I mentioned before, there are 2 approaches. The first trials were focused on high-dose immunotherapy. And the latest approach by Immune was low doses immunotherapy. So over the course of 6 months, the kid will increase the amount to reach a 300 milligrams target dose. And the other difference of this approach is that the treatment was not the natural food, but peanut powder produced in a manufacturing plant following the same protocols as if it was a medicine. In the phase 3 clinical trial, they demonstrated that the treatment was efficacious in preventing reaction after exposure to the amount of 600 milligrams. So after 12 months of treatment, 67% of the patients in the active group passed the oral food challenge with 600 milligrams, in contrast to the 4% in the placebo group. This trial was performed in different centers across the US and in Europe. What we know about the safety of this treatment, and there are reactions, particularly during the build-up phase. My group performed a systematic review on how safety was reported in trials, in clinical trials and control trials, as well as real life studies. Here, since we were looking at safety, all the studies reporting reactions were included. Overall, 80% of the participants reached the target maintenance dose, but we know that about 11% of them will leave the treatment due to adverse reactions. And This was very variable among studies, and in one of the trial, even the 34% of the participants abandoned the treatment. And the main factors to abandon the treatment were either anaphylaxis or the occurrence of gastrointestinal reactions. And this can be mainly abdominal pain or esophageal disorders. So we don't really know how many patients are affected by this, but it's an important number and is something to be considered. But we cannot really compare what happens during the build-up phase when we are increasing and we are trying to get the patient desensitized with avoidance, because we are exposing the patient to the food. It would be more important, and it would give us more information to compare what happens during the maintenance phase. And we don't have that many reports on that. We don't know how many reactions happen during the maintenance phase. Usually less than during the build-up phase. We know what patients are at higher risk of having reactions. We know that those that had anaphylaxis previously, asthma, a low reactivity threshold during the oral food challenge, and higher specific IgE or skin prick testing are at highest risk. And we need to individualize the protocol. Maybe we need to do smaller increments during the build-up phase, or we need to extend this phase for longer than 6 or 9 months. And eventually we might need to consider to decrease the target dose. Maybe if we are aiming to get a high dose maintenance phase, maybe we need to try to get the patient to tolerate 50 milliliters of milk, or half of an egg, or 5 peanuts, for example. We can also consider adding other therapies as anti-IgE, as I will mention after. Dr. Khalifa mentioned how important cofactors are, and they are really important in this treatment as well. So we know that an irregular intake leads to the occurrence of reactions. The patient needs to take the dose daily. They cannot take the dose on an empty stomach. You need to avoid exercise for at least 2 to 3 hours after the dose. Anti-inflammatory medication should be avoided, and only use acetaminophen is needed. When the patient has an infection, we need to carefully adapt the protocol, sometimes to reduce the dose, sometimes to stop the treatment, depending on the infection or how well the kid is. But most important, or the fundamental cofactor for this treatment, is asthma. We need to have asthma under control. So how do we evaluate the patient, and how we decide when to start? European guidelines say that oral immunotherapy is indicated for patients with evidence of or IgE-mediated food allergy when avoidance is ineffective, or the patient and families have severe limitation in quality of life. And it has been mentioned before how difficult it is to avoid foods, especially for those patients with very low reactivity thresholds, and how difficult it is to follow or understand the labeling, because many companies, just to prevent, they say may contain, which is really difficult to to have an idea of if the food has or not, or if the meal has or not the allergen. So for the baseline screening, we need to get a very detailed medical history. Some of the patients are referred from other centers, so we don't know them from the beginning of their diseases. We perform allergy testing, and we always do an oral food challenge, maybe with the exception of kids that have had recent reactions or have reactions with traces that happened in the last year. Another key question is, do the family understand what this treatment implicates? Patients and family need to know that it's a very long treatment that takes months. They will need to make some adjustments. Some of these kids practice sports. They need to change that. They need to adapt their extracurricular activities. Some families travel a lot. Other parents have very demanding jobs. So all this has an impact in treatment. And we need to evaluate comorbidities. When some particularities of this treatment is that we do the increases at the hospital, but the patient need to take the dose at home. So parents need to be able to determine if the kid is well enough to receive the dose. They need to prepare it, they need to administer, and they need to treat the reaction if it happens. So it's very important to have a very detailed action plan written. And they need to be able to tell the kid not to exercise, and don't forget to give anti-inflammatory medications. So in previous medication presentation, it was mentioned the use of monoclonal antibodies. Here, we have tried to increase the safety of this procedure by adding omalizumab. And there are some reports of that, but the information is still limited. I will mention 2 clinical trials. This is a phase 2 double-blind placebo-controlled over 28 weeks, including 57 patients from 7 to 32 years old. And there were no differences in efficacy, but omalizumab group had less reactions compared to placebo group. In this other trial, omalizumab, this was also 28 weeks with younger patients from 6 to 19 years old. Omalizumab was efficacious in allow a rapid desensitization, as fast as 8 weeks compared to standard protocols that take months. I would like to mention the results of this observational registry in Spain, and this group collected information on how omalizumab was used off-label in daily clinic to treat patients that underwent to oral immunotherapy for milk. So how omalizumab was prescribed? It was indicated for asthma in 32.8% of the patients, and for the rest of the patients, the 2/3 of the patients, the indication was food allergy, so cow's milk allergy in this case. either because oral immunotherapy was tried before and was not successful, or the physician considered the patient was very severe to start the procedure without omalizumab. In this registry, each physician decided when to start the treatment and what dose. So the most common dose then was 300 milligrams every 4 weeks. And what they show is almost all the patients, except for 4, were able to tolerate and to reach the maintenance dose. And most of them reached the target dose of 600 milligrams of milk is around 200 milliliters, so a glass of milk. 4 of them couldn't tolerate that amount and stay at half of the dose, or a bit more than half of the dose. And 4 of them failed because they had recurrent reactions or severe anaphylaxis, and one of them was diagnosed with eosinophilic esophagitis. So it seems it gives some protection and facilitates the treatment.
Hello, Dr. Emma. Dr. Emma, sorry for interruption. We are actually very nice talk, but we are already running out of time because long day today. So could you have 5 minutes more if you can?
Oh, okay.
Thank
Sorry.
you. Thank you.
So what happens after stopping omalizumab? There are a few studies describing that, and all of them show that some patients have reactions, and some of them are severe reactions. So we know that might facilitate oral immunotherapy, but we don't really know when we should start. It has been proposed 2 to 4 months before the treatment. We don't know for how long, and we don't know if it will affect the efficacy of the treatment. And we cannot forget this is an expensive medication. We should analyze the cost efficacy of it. So what we have so far is expert opinion, and this treatment should be added when conventional schemes fail in very high sensitized patients. Since we don't have much time, I won't be mentioning much of the future approaches. We have other monoclonal antibodies, and we have other forms of immunotherapy as T-cell epitopes or allergoids or virus-like particle proteins added to immunotherapy. And so just to finish, we have IG-mediated might affect 10% of children and adults. There's a global increase of food-related anaphylaxis. Oral immunotherapy is affected, but it can produce a high degree of it's effective. It can produce a high degree of desensitization, but we cannot forget that we have reactions, especially during the build-up phase. This is a very long treatment, and patients and families need to accept it. They need to be compliant with the protocol. We cannot forget cofactors. We need to have asthma under control, and we might consider adding omalizumab in more severe cases. And this is all for today. Thank you.